I'll tell you guys about what we do, or maybe I'll tell you about what I do and kind of why I'm here to talk to you. I'm not a neurologist. I'm not a brain doctor. I am primarily, my day job is as a pulmonary and critical care doctor. Pulmonary is lungs. The only time it's been cool in recent history to be a pulmonologist was in 2020. And then since then, it's kind of, no one knows what it is. But, so what I saw a lot of in my work as a pulmonologist, as an ICU doctor over the last 8 years in this community is people get really sick and they go into the hospital. The hospital is built, it is what it is, it's not good, it's not bad, but the hospital is built to get that person out as fast as they can. You can make an argument that that's good for the patient, you can make an argument that's bad for the patient, but it happens, and because it happens, we see bad things happen. And so some of the issues that we see, saw a lady come in with a blood clot, DVT, starts down here, moves up, goes into the lungs. That's called a pulmonary embolism. That's very life-threatening. That recently killed an actress from Schitt's Creek in California. And this lady came in because she couldn't afford the medication. Well, she didn't think to call and ask for help. Was she embarrassed? Was she just unaware? I don't know. She nearly died. We were able to get her back. We see people go home. They're on new insulin, right? They're injecting themselves. They don't really know what they're doing. They overshoot. They can die from that. They undershoot. They can come back in with life-threatening DKA or diabetic ketoacidosis. So we all have a million of these stories, and so it kind of started us on this journey of what can we do to bridge the gap? Because I guess most of you have a doctor, and if you picked up the phone today and you said, hey, doc, I need to get in, they would have a hard time doing that, And so when these people leave the hospital is built to say, here's your discharge paperwork, here's your prescription, here is your instruction to call your doctor, good luck, have a great day. And they call and they can't get in for 8 weeks and bad things happen. So that's where Pikes Peak Discharge Clinic really exists. And, we enter into that area, not to take over, but just to bridge the gap to help these people. We also do a lot of helping of people who are on home health and hospice and stuff like this. We're there to bridge the gap. Asked to talk about what happens to the brain when you're sick and in the hospital. Again, as an ICU doctor, we see a lot of people come in with a variety of things. So sepsis, congestive heart failure, CHF, urinary tract infection, these types of things. They don't come in with a brain problem. But then, over time, as their body remains ill, their brain starts to do strange things. They start maybe picking at their skin. They start talking to people that aren't there. They don't know where they're at. And it's my observation of family members, it's really freaking scary. Why is this happening to my loved one? Aha. So this is what we call delirium, okay? So delirium is different from dementia. A lot of family members say, oh my God, does my family member now have dementia? And happily we can tell them, well, what we say is no, this is just delirium. Maybe they do have dementia, but we're not going to make that diagnosis. So delirium is an acute change in mental status. It causes a fluctuating level of consciousness. So we talk about kind of this sine wave, right? So people will be hyperactive. Maybe they're trying to jump out of bed or trying to run out of the hospital. And then we can see it go hypoactive, where they're just sleeping all day, hard to wake up. They don't know where they're at. And so they go through these big sine waves of kind of fluctuating levels. They can't pay attention. Their awareness is off. A lot of times in people who are very high functioning at baseline, they can be delirious and it's hard to catch on to it. But then you ask them where they're at and they have no idea. And you ask them, the year, they have no idea. It is reversible. And the way we do that is by treating the underlying issue. Delirium is very important. We see it generally in the older population. I'd say oftentimes over 65 is when we think about it, but we can see it in any age group. That's especially true if someone has a history of substance abuse. We see it very commonly in people who have abused alcohol over the years. They come in and delirium is one thing, alcohol withdrawal is another. If you add them together, it can be very difficult to manage. Very hard on the patient, very hard on the family. It's linked to longer hospital stays, higher mortality, and increased healthcare costs. So again, all of us are here to support the individuals in our community who have a sickness of one sort or another. The longer someone stays in the hospital, even if we think they get discharged too early, the longer they stay in the hospital, the more bad things can happen. And so delirium 100% keeps people in the hospital longer and allows more bad things to happen. So the common causes that we see, we talked about infections, urinary tract infections, pneumonias. Do you guys know that oftentimes the first sign of a urinary tract infection, this is especially true in elderly females, the first sign is oftentimes confusion, which again is very strange. And the family says, well, my God, is there something wrong with her brain? Is this a stroke? It could be a stroke. Sometimes it looks like a stroke, but oftentimes it's delirium related to the underlying urinary tract infection. Homeostasis, that's that balance we have in our bodies. When you're in homeostasis, things are happy, things are working, we're clicking. When you're out of homeostasis for one reason or another, it's not good, and the brain can be affected. Things that can cause that, dehydration. I, in fact, have someone in the intensive care unit right now who is in there because of a low sodium level, electrolyte imbalance, and that affects the brain. Fix the sodium, fix the brain. It'll be okay. Medications, we see a lot of post-operative issues. Through the discharge clinic, we see people who come in, whether it's a traumatic injury like a fall and a hip fracture, or maybe it's an elective surgery. Generally speaking, doctors are pretty nervous to prescribe narcotic medications because bad things do happen. But if they're undertreated, if their pain is undertreated, they can have delirium, they can have issues related to that. Certainly, if they're overtreated with narcotics, that can be very detrimental. But these are the things, you got to find that homeostasis on both sides of that balance. Surgery and anesthesia can cause it. Stroke, we all, talk about signs of stroke all the time, heart attack, sleep deprivation. So that is one thing to talk about. In someone who has kind of an at-risk brain, whether they have underlying dementia, advanced age, other significant medical issues, a change in daily pattern can be very detrimental, whether in the hospital or not. So if someone moves facilities or moves homes or moves communities, that can make them look a lot like a dementia patient for a time. It can be very difficult. If you come into our hospital and you have a stroke or stroke-like symptoms, for the first 24 hours that you're there, the nurses wake you up every hour and they do a neuro assessment. In one regard, that's good. We want to check and see if your stroke is getting worse. But in another regard, that's very hard. And a lot of folks become delirious just instantly. The next day, they're just totally out of it because they're being woken up every hour. And that's a lot to put on the body. So the signs and symptoms. So again, confusion, disorientation, reduced attention span, hallucinations. That's something that's really hard for family members to see. Their loved one, they've been clean living their whole life, and all of a sudden it looks like they're just on an acid trip, right? And so they're feeling spiders, they're hearing a dog in the room, and it's really crazy the things that the brain can do. Sleep-wake cycle disruption. Again, going back to the importance of sleep, we see this happen in the hospital where you come in sick and you stay up all night, whether or not we're waking you up, and you sleep all day. That's hard. That can be very difficult on the patient. In a lot of ways, what we try to do in the hospital is going back, I've got young kids, and so going back to how do we manage children? You try to get them to sleep, at least in the Merrick household, try to wear them out during the day, take them to the pool, feed them and get them in bed, and then go to sleep an hour later. But that's okay. So sudden personality changes or behavior changes. So sometimes people get mean. People talk about, this idea that there's a mean drunk and there's a nice drunk. We kind of see that with delirious patients. Some people are really hard to be around, even for the hospital staff. And we know what's going on, and they're just still hard to be around. Again, when you think about how this affects your clients, our patients' families, it's a lot. It's a lot to handle, and they start second guessing, can I get this person home? Can I take this person home? So I think, here's the really important thing that we try to communicate to patients and their family members. Dementia versus delirium. I do not know the standard rubric for diagnosing dementia, but I do know there are some common themes. And so when we're talking about dementia, that's going to be generally a more gradual onset over time, months or years. It's going to be a steady decline. Normal levels of consciousness, right? You guys, many of you work professionally with people who have dementia. Many of you probably have family members. And over time, you see this kind of steady decline. And it's this less kind of violent, rapid change that we see with delirium. And again, that makes it very hard on family members because it's just kind of this flip of a switch. And so we try to educate them that, hey, generally in medicine, if something comes on fast and doesn't kill you, then we can usually reverse it pretty quickly. If something comes on slow over time, it generally, if it is reversible, takes time to further reverse that. So we're going to be hearing in a few minutes about how to support family members and loved ones. But this is kind of where the crux of the issue is when I'm treating someone with delirium. And I say ICU delirium because I only work in the intensive care unit. But in intensive care, it's pretty prominent because it's high-intensity nursing care, respiratory care, vital signs every hour. You've got the cuff here. You may have an arterial line here. You might have a breathing tube in your mouth. You might have a big IV in your neck called the central line. All this kind of accoutrement of helping people can also create pain, agitation, and then you've got the beeping, the constant beeping overnight, blood, the vital signs and stuff like this. So family members can't do anything about that, right? So it feels pretty helpless and hopeless to them. But what we tell them is, but you can be here with your loved one. And in my hospital, during COVID at least, there was a 24-hour visitation. Now I think family members are asked to leave at 10 p.m. You can come back at 6 a.m., 7 a.m. So you can be with that person most of the day. But at night, they need to sleep anyways. So go home. Go home and rest. Take care of yourself. Get a shower. That helps a lot. All joking aside, it really does. And so the thing, when you come back, help us keep your loved one awake. Okay? At night, lights are off, television is off, just like managing a child. During the day, lights are on. We're talking to them. We're telling them where they're at, why they're here, when it is, what's going on. And we're reminding them that you are safe, right? So we're all familiar with kind of the fight or flight, right? So we've got the top part of the brain, which is the executive function, and then the bottom part, which is, I got to get out of here. I need to do something because my animal brain is really scared. And so these people who are suffering from acute delirium, their executive function is pretty well shot. And it doesn't matter how much I tell them, you're okay. They don't know me. But there's something really beautiful and magical that happens when a family member comes in and says that. It's a really neat thing. And so we really rely a lot on family members to help with that. And communicate early with hospital staff. If you see something, say something. Oh, this is interesting. Favorite blanket or personal item. Very helpful. We've got a young guy in the ICU right now. He has an axolotl. Does anyone know what an axolotl is? Yeah, like 5 years ago, no one knew what it was. Now everyone's got an axolotl. So anyways, those things are very helpful. What you can expect from the medical team. So this is the way that I was trained, and I've experienced it to be very true, that managing delirium is like playing racquetball. So in playing racquetball, if you're running to get the ball way over here, and then way over there, and you're chasing it, you're going to miss it. In racquetball, if you can stay in the middle, then you have a much better chance of getting it back, okay? In the same way, people with delirium are all over the place, okay? So one minute they're asking for a drink, then they're asking for food, then they're sick and vomiting, then they don't want any of that, then they want you out of the room, then they want the TV on, then they want the lights on, then they want the lights off. All these things, as a medical team, it can come across as lacking compassion. And maybe sometimes it is, but to go by the book here, Managing someone with delirium is staying in the middle and being ready to respond when needed, but generally letting their body work it out, okay? There was a trial, medications that we use, I don't really get into this in the slides, but I should tell you. So medications that we use in the intensive care unit for this historically are antipsychotic medications. We avoid medications like benzodiazepines, which would be like Ativan or Xanax or something like that. We know that those benzos, as we call them, can make things worse. They might feel good to the medical team because they'll knock that person out for the next several hours and then we can all get something done, but it's the wrong thing for the patient. And so there was a study that looked at, okay, well, what if we take people who have hypoactive delirium, where they're maybe picking at stuff a little bit, but their brain is just not right. They're not jumping out of bed. And what if we schedule medications like antipsychotic medications like Seroquel, maybe one you've heard of, Zyprexa, maybe one you've heard of. And we refer those sometimes as brain glue. And this medical trial showed, you know what? Didn't help. Made the medical team feel better, didn't actually help the patient in terms of number of days to leaving the ICU, number of days to leaving the hospital, and the amount of time that you survive in the next 30 days. No change. So that kind of, for us in the ICU, kind of reinforces the fact that it's up to us to just manage the patient. Don't chase them with medications. We still use those medications, especially for people with hyperactive delirium, because we don't want them jumping out of bed, hurting themselves, hurting a staff member. Oop. I get this question a lot. Will my loved one ever return to normal? And the answer that we generally give is yes, we think that they will. We have had cases in the ICU. I'll speak as a pulmonologist. We put a lot of people on the ventilator because they come in with respiratory failure. To come off the ventilator, I'll give you guys this tidbit if you ever have a loved one. You need two things. You need working lungs and a working brain to come off the ventilator. And people who have been on the ventilator have been under a profound amount of medication for a medically induced coma. We get a lot of propofol. That's the white stuff that Michael Jackson OD'd on. So we give a lot of those medications as well as fentanyl. And so when we start to wake someone up, because we say, oh, okay, so your pulmonary function's better, you're breathing easier, you're on minimal oxygen, things are good, let's wake them up. The family expectation is generally great. They're getting better, they're going to come off the ventilator. Personally, I've tried to get a better way to communicate this to families because that's a hard expectation to manage. Because when they wake up, they're generally a little bit confused. And we need you awake. We need you to be able to follow commands to cough and to take a deep breath. Very minimal, but people with significant delirium can't even do that much. So we do have cases where people have had to get a tracheostomy because they can't come off the ventilator. Here's my point. It's not about respiratory failure, but it's generally to say most people come through that. It does take time. There are cases where it does become a terminal event. And those are very difficult because you tell the family, like, my God, like their body, their organs are working okay, but their brain is just spinning out of control. And those are very hard cases. But generally speaking, these people do get better. As a pulmonologist, I'll see a lot of my patients back in clinic after they leave the intensive care unit in the hospital, see them back. And for me, that's very rewarding because I get to see them at their worst, hospital gown, stinky from being in the hospital, totally out of it. And they come in and they look like $1 million. So that's great. And for me, that's a very reassuring experience that I give to my patients and their families to say, I think they're going to be okay. We don't have long-term trials that look at, well, what about a year later? What does that look like? But going off of kind of the overall body of knowledge, the understanding is they're probably going to be okay. During COVID, we would have people on the ventilator for 4, 5, 6 weeks. We did hear from family members during that time that that individual maybe had some permanent personality changes, so there is that. But they didn't develop dementia, at least in the near term. Long term, again, there's no studies. But in the near term, they weren't suddenly a patient or an individual with dementia, but maybe a little changed. So, just to recap, Delirium, sudden onset, waxing and waning symptoms. The treatment for this is to manage the underlying condition. What we do is, as the team, we stay in the middle. We manage things as they come. What we don't do is chase every little symptom. Our biggest ally are the patient family members. And so as healthcare professionals, the more we can do to advocate for family members to be at the bedside, especially during transitions, as we think about changes in sleep patterns, and I mean leaving the hospital, changes in sleep patterns, changes in pain, medications, medication withdrawal because we've had you on fentanyl for 5 weeks in the hospital. All these things, the more we can advocate for family involvement, the better our patients will do. And so with that, I will answer any questions, and then I'm going to turn it over to my friend here.
How common is it?
I would say very common. Very common. So much so that it's somewhat expected, and that's where it's hard as an ICU doctor. It's just like, 85 years old, here with a UTI and septic shock. They're confused. Okay. But again, that's where that compassion comes in. If I need to realize this is new for the patient family because she was totally independent yesterday. Yeah, but very common. Yes, ma'am.
So is it like correlated to level of care that they're in? So like ICU patients, you're going to see it way more often than just like a med surg floor or general inpatient type?
Absolutely. Absolutely. And I would say that's twofold. One is because to get to the highest level of care, you have to be the sickest patient. And then at the highest level of care, you get the most medical management. And I'm telling you, I more and more am just like, there are a lot of things in medicine I believe in. But my God, sometimes we just overdo it. And so these people get so much, it's very hard on their brain. Yes, ma'am.
I noticed you didn't list underreported alcohol or drug abuse, because I used to see that in ICU.
Yes. Were you an ICU nurse? Oh, I love it. Lisa, that works at Pike's District, is an ICU nurse I used to work with. Special place in my heart. Any ICU nurse. So, absolutely. The rule of thumb, and this is maybe a bit jaded, I'll cover my, but the rule of thumb is you triple whatever number you're given. And you are exactly right. You are exactly right. We see so much of that. The thing that's really hard is people, this isn't a statement one way or another, it's not ethical, it's not moral, just is people that use a lot of marijuana, very difficult to manage, especially if they're having a lot of pain. It's very difficult to get them enough medication and their brain starts spinning. Yes, ma'am. Well, shoot. Generally, the way we think, I phone a friend. Generally what we think about is all those receptors are so saturated constantly because there is cross-reactivity that, okay, wow, my God, you are in pain. I believe you. I don't think you're drug seeking. I want to help you. Here's some pain medicine. Nothing. Same with procedures. We do a procedure as a pulmonologist called a bronchoscopy. And for that, we'll give our own medication to put the person to sleep. And those individuals are very difficult to sedate. So anything extra that we're bringing into our bodies changes that physiology. Great question.
Does the percentage go up the longer you're in the hospital, I'm assuming?
It does. Absolutely. So we try to, again, this is that cuts both ways, but we try to get you better, get you out. But then again, that's where bad things can happen. But absolutely, the longer you're in.
So,
yes.
when I was working with dementia care, we get a lot of diagnoses where they have dementia and delirium.
Ooh, absolutely. Oh, I need to add that to the slides. Yeah. If you come in with delirium, that bowling ball is already rolling. And so, did I say dementia? If you come in with dementia, then your chance of delirium in the intensive care unit is nearly 100%. Nearly 100%. It's extremely difficult to manage and extremely difficult to work with families in that setting, especially families who have not had much education in their loved one's health.
So that's not common to see those two diagnoses together.
No. And oftentimes what we'll see, and again, not as a brain doctor, but we'll see kind of this stair step thing. we see a lot of stair steps in medicine. For instance, if you are 80 and you come in and fall, break your hip, stair step. Getting back to where you were is profoundly difficult. It's much easier to die than to improve. And so we see the stair step. So now you're in a rehab facility. Shoot, you get a urinary tract infection, stair step. And so once this starts, and we see this, and by the time you get to me in the intensive care unit, it's in retrospect, this train has picked up a lot of speed. So we see that with dementia oftentimes, that kind of stair step. Again, clinically, just from the general doctor standpoint. Yes, ma'am.
Yeah, and so part of that we have to be careful with also is the long-term effect of all that, of surgeries and hospitalization, is depression.
Ooh.
And that can present as dementia, and so we have to be careful with that.
Yes, absolutely. That's such a good point. Yes, ma'am.
My lack of knowledge on it, but in some personal experience, can that also be leading to like sundowners and things? I don't know.
Yes. Yes. Absolutely. We'll use that. We throw around kind of a lot of terms like sundowning, delirium, altered mental status, encephalopathy. But yes, you're exactly right. Have you ever noticed, like if you have a sinusitis, you always feel worse in the evening? I think that's the same for the brain. It comes to the evening and it's just rough.
So should you be treating the dementia or the delirium?
Yes. That's right. Great point. We do try, a lot of people are on this medication called Aricept for their dementia. We try to keep that going, when they come in. Something else, this is a plug as a pulmonologist. Have you guys ever heard of the term aspirating? Like medically, right? So if you're aspirating, my ICU nurses know that. So we see that a lot in people. If you have a sick brain, you're more likely, generally speaking, to aspirate. And even at our hospital, we have had a lot of quality issues related to aspiration. So the trachea and the esophagus are right next to each other in the throat, right there. And so when you're drinking or eating, it takes no effort whatsoever to accidentally pull that down into your lungs. That's especially common if you're confused, elderly, and weak. And that's generally who these people are. And now you take a hospital system that's overrun with sick patients, lots of new staff, and these people are sitting in their beds like this. And so you come in and they've got scrambled eggs just going down, which I can't stomach, actually. It's a lot. But the people, that's very dangerous. It's very dangerous. So be aware of that. Okay. Yes, ma'am.
I spent some time as a long-term care nurse.
Oh, yes.
And I think in both transitions of care where someone's going home or they're going to a physical rehab for a stay after a hip, or going into long-term care for a residential setting, I think family members and I think staff need to know that one of the very first signs that something's wrong, and it's usually, as you said, urinary tract or respiratory infection, you see this change in them that you need to do something ASAP when you see those. And I tell my nursing students this all the time because it's so easy to miss.
Yes.
And I think, moving from one, I love the stair step, but moving from one level of care to another, it's another opportunity for the delirium to take over.
Oh, man, absolutely. Thank you. That is a great point. That is a huge issue. Okay, well, this has been a blast. I thank you guys. Where's my friend at? There she is. Okay, I'm going to baton pass. We've got a great resource here for you guys. You need an introduction, which I cannot give. But
I can introduce myself. I know almost everybody here.
they know you. She needs no introduction. Thanks for coming up. Thanks for talking.
Awesome.
Yeah.
Well, hello, everybody.
Does she need this?
I'm Cheryl
Hold on.
Sawyer.
tech guy here.
Oh,
Yeah, put that
yes.
on. Put
How
that
do
on your
we?
lapel there.
Thank you, thank you. My name is Cheryl Scheuer, and I know most of you, and it's so good to see a lot of you that I haven't seen for a while. I have been a volunteer, what's the title now, Rosemary? Community educator for the Alzheimer's Association for 25 plus years. I've been a memory care director, and I also have the absolute privilege of being a TIPA Snow certified instructor and coach. I own my own business called General Shepherd Dementia Training, where I work with care communities and care professionals. But the thing that I really want you to know about me is that even though I've had 20 plus years experience working with folks with brain change, I'm the daughter of a mother who died of Alzheimer's. And her journey was not pleasant. She had it all. She had delirium, hallucinations, delusions, and it was a pretty wicked journey with her. When she was in Oregon before she moved here, probably 3 or 4 hospitalizations. And the hospital in Corvallis, where the town that she lived in, was a teaching hospital. And boy, was that an experience, because even though I, as an educator, knew the disease and how to work with folks with brain change, the staff did not. And every hospitalization was a nightmare. Just as an example, they put her in a shared room, right next to the nurses' station. So we know how loud nursing stations are. The person next to her snored, and mom, with her delusions and hallucinations, thought it was the devil in the bed next to her. And that was a nightmare. Like you said, coming in all hours, every couple of hours to check vitals, et cetera, et cetera. And then I remember the CNA. Oh, this just really gets me going. The big male CNA came in, hauled her out of the bed, and said, "Pivot, Carolyn, pivot." He was trying to get her to take her to the bathroom, and he said the word pivot. Well, here she is on all these medications. She's going through hallucinations, delusions, et cetera, in severe pain from broken hip, and he was telling her to pivot, and he picked her up, and yeah. So you can tell I'm passionate about educating folks about how to work with a person with brain change when they're hospitalized. And here's the number one thing I want every single one of you to remember. Hospitalization will happen. Hospitalization will happen. Or it could even be something like just an urgent care kind of thing. So the takeaway from that is be prepared. Be prepared. Carol, you have an awesome opportunity with your care community as part of the move-in process. The handout that we have here for you. Can I get a volunteer to pass these around? Yeah, Kimberly, can you? Thank you. And if you need more, we'll get them to you. Be prepared. Oh my gosh, because it's going to happen. So educate your families, those that are care professionals. Educate your families on what to do to be prepared. And this handout that you're going to get, I'm not going to go over the whole thing because we're all adults and we can read, but it's from the Alzheimer's Association, one of the groups out in California. They have some phenomenal ideas on what to do to be prepared. But I want to give you folks some key things that are really, really important that my family learned. And when I was a memory care director, absolutely, we educated every family, get this done. So first thing to do is know who your backup team is. Because if your person has to go to the ER, ICU, the whole thing, you've got to have a backup team to know who can be there to support you. I remember as a memory care director, we had one resident, she was such a sweetheart, and her family were all out of town. So I took her to the emergency room, and you know how that could be up to an 8-hour process while we were waiting for the family to come in, fly in from out of state. And had they had kind of a backup system, it could be neighbors, it could be folks from the church, it could be relatives, it could be whoever, but have somebody to be your backup team, because it's very probable that you will be in the hospital 24 hours bedside with your person. Unless you hire a sitter, but then a sitter, like with companies like, Suzette with her company, with Sage's Elder Care, the person is not going to know who that caregiver is. So be familiar with that. Another thing that I really want to stress that's not on your handout is remember that folks living with brain change, with any kind of dementia, stability, security, common things are extremely important to them. You mentioned the fuzzy, comfortable blanket, but they're used to, and the dementia brain cannot sequence, can't process that, ooh, I'm here in the hospital, ooh, maybe the doctor's gonna come in, or the nurse. The dementia brain cannot process that. So stability, security is important. A key thing that families can do is put together a goodie bag. Oh my gosh, this saved our life with my